All right, let's call this meeting to order. Included in your packets are copies of the minutes from the April 16th public meeting of the Commission. If there are no changes or corrections, I'll entertain a motion for approval.
So moved.
Okay.
Commissioner Khan.
Okay, who's on the phone? So we've got Commissioner Khan. Who else?
This is Commissioner Stellenwerk.
Okay, terrific. Well, welcome. Any discussion? All in favor?
Aye.
Any opposed?
Aye.
Minutes are approved. Commissioners, you've received the written updates from our centers. Ben, do you or any center directors have anything you'd like to add?
So I wanted to just note that over the last month we've had several significant work group meetings. The cardiac services work group met last week and reviewed the draft proposed regulations. They have not been formally submitted to the Commission. We got some important comments from several of the systems, and we're continuing to work through with the work group some of the technical issues regarding definition of cardiac surgery and open heart surgery. We would expect to have those draft proposed regulations brought before the Commission in July. We're also continuing to work on, no meetings were held, but there is staff work going on with the Home Health Agency State Health Plan. That's significant revision, opening up the authority, providing more flexibility for agencies to expand around the state, and I think we'll be looking for comments over the summer as we bring those regulations forward for stakeholder comment. We're also beginning work on the freestanding medical facility state health plan. We are required to have a plan out after July 1. We're not ready yet to convene any public groups on that, but staff is working to meet that deadline. Freestanding medical facilities have been three have been in existence in the state, but there's been a moratorium for several years. With the publication of our evaluation in January, we are also responsible for developing a plan for how these facilities might be established going forward. We'll be working very closely with HSCRC, consumer groups, and the hospital and provider industry in developing the state health plan in that area. I think it's going to be pretty exciting to have a new type of facility, but at the same time, there'll need to be some concerns considered on how that fits into the new global model. That concludes my update.
Any center directors? Okay, move on to agenda item number 3, which is the Care Coordination Report. The Care Coordination Work Group was formed to provide the Health Services Cost Review Commission and the Department of Health and Mental Hygiene with advice on how hospitals, physicians, and other providers can work together to develop effective care coordination programs to support the goals of Maryland all-payer model. Jack Meyer, consultant with Health Management Associations, will present their recommendations from the work group. And then the co-chairs, Carmela Coyle, the CEO of the Maryland Hospital Association, and Laura Herrera-Scott, the Deputy Secretary of Public Health Services at DHMH, will offer their perspective.
Good afternoon. I think I'm going to kick this off before we hand it off to Jack. Thank you very much for the opportunity and the invitation to be here to talk a little bit about the outcomes of the Care Coordination Work Group, a work group that I was asked to and agreed to co-chair along with Dr. Laura Scott. Our thanks to Ben Steffen for having been a participant in those important conversations. And one of the reasons, at least that I agreed to do this work, is because we believe it's critically important to the success of the new all-payer model in the state of Maryland, the new waiver that we have Recall that that all-payer system is now part of a 5-year experiment that changes both the way in which we pay for and provide hospital services in the state of Maryland. The agreement that was ultimately reached with the Centers for Medicare and Medicaid Services was an agreement that embraced 5 metrics, 3 of them financial, 2 of them quality, where we focused on putting a ceiling on the rate of growth in hospital spending in the state, guaranteeing savings to the federal government, making certain that our total health care spending trend, not just hospitals, but hospitals and non-hospitals, stayed below that of the rest of the nation, and 2 important quality metrics around reducing readmissions and reducing complications. But as you can hear, that was very much a statement of the what it was that hospitals were expected to achieve. And the reason this work is so important is because it was all about the how. So clearly articulated what we needed to do. In terms of the hows, of course, the big game changer was the move to global budgets, completely changing the economic incentives that hospitals in the state of Maryland face in terms of the care that they provide. But the hows are all about the changes that are going on within hospital organizations to actually manage under those tight spending limits, to reduce readmissions more rapidly than the rest of the nation, to reduce complications and infections dramatically. That is the hard work that's now underway in Maryland's hospitals. I was saying to Jack, as we met and negotiated at the end of the day with the Centers for Medicare and Medicaid Services in the state, it wasn't just about lower costs. It was really about meeting the triple aim. It was about whether we could build a better mousetrap in Maryland. Could we deliver care in new and different and innovative ways? And that's what leads us to this work group and the work that we were engaged in over the last several months, that this work group was really an opportunity for us, and a unique opportunity, to focus together as not only a hospital field, but as a healthcare system, if you will, across the state, and say, what are the 1 or 2 or 3 key accelerators that we might invest in together as a state, places where we could collaborate to actually make care coordination move faster. That's really what this work is all about. I know Jack will walk through the report in more detail. I draw 3 highlights to your attention. There were many recommendations, lots of conversation, lots of discussion. But the places where we really thought there was a unique opportunity for us to accelerate activity as a state, one, no surprise, around data infrastructure, tremendous opportunities for us to not duplicate, but to actually take advantage of the need to identify those high-risk patients for whom we need collectively to manage their care. A second and critically important area was around this notion of care profile. Not detailed care plans, but is there a way we can begin through our health information exchange to share some basic information that everyone can reach and touch, usable and viewable? Jack will talk more about it. And the third, no surprise, behavioral health. This has been an issue that has come up in every conversation we've had about the waiver, the challenges we face in this state. And so another accelerator for care coordination, how do we focus on new and innovative models to really see if we can manage the behavioral health of the population in the state of Maryland. So that is an overview and a little bit about what got us started. I would like to ask if Dr. Scott would like to add anything, and Jack will take us through the details.
I'll turn it over to Jack and add my comments at the end.
Okay, I might move down one so I can see you all kind of hidden behind the screen. Thank you. Guessing this moves. Okay. Thank you. I want to start by saying that I was a lucky guy to work for 6 months with 2 co-chairs who were both very intelligent and knowledgeable about the subject matter, but also a pleasure to work with. Made my job a lot easier. We also had 18 experts on this committee, including your own Ben Steffen, who came to all the meetings and participated very constructively, as you would expect. And they were from widely different perspectives, positions, and mental health experts, and really quite a mix of people that made my job a lot easier as the facilitator. I want to start by echoing some of the things that Carmela said. Given the tight targets in the all-payer model, it's really become important in implementing the model to recognize how we need to move upstream in the care delivery system, not to reduce the critical role that hospitals play, but really focus on what is driving people into the hospitals and focus heavily on advanced primary care and work we can do outside the medical model in the social determinants of health. I know you are big on that and have done great work in the state on that, Fran, and others. I'm just starting a project now for Prince George's County to help them redesign their behavioral health system, something that Carmela stressed. And as I was reading the statistics a day or two ago, focusing at first on children and youth, you can't help realize that if you're going to work on behavioral health in Prince George's County or any other county, you've got to be looking at the school systems, you've got to be looking at the criminal justice system, the juvenile justice system, housing, employment, and a variety. The statistics on the number of kids that hit the behavioral health system in that county who have been physically abused or sexually abused, or who live in the household where at least one person has been in and out of jail, are shocking. I was almost thinking, how could a person not be hitting the behavioral health system growing up in such difficult circumstances? But we know in healthcare and under these new regional partnerships, hospitals in the state, hospitals will be working with collaborators in their region to work on some of the problems that drive people into the healthcare system, and some of the barriers, including language and lack of transportation and a whole variety of problems. But we're focusing on people with multiple chronic illnesses and how to better manage those illnesses in the community to avoid flare-ups and avoid complications and get them the care they need, whether it's diabetes, asthma, hypertension, congestive heart failure. I'm shocked by the number of people in the Medicare population that have all of those, and they also have mental, emotional, and it's really hard to know which is driving which. So we know that we need a holistic approach. I'll say more about that in a little bit. But we have to, under the new incentives, hospitals are now at risk for admissions that are too high, readmissions, and exploding outpatient care. We have to focus on not only improving health outcomes, but the functional status of people as well in the elderly and disabled population. That's critical. Let's move on to the next slide. I want to just say a few words about my sense of the conceptual model, which is that the state of Maryland can serve as a facilitator and a catalyst for investments in infrastructure that would likely otherwise be under-resourced. And we economists call those public goods, things that would not appear and benefit everyone, but in a strictly private investment model would probably be underinvested in. What we're seeking is the right mix of standardization and flexibility. This is not about the state running things or the state driving all change in the healthcare system. Instead, this is about the state providing toolkits and infrastructure that serves as a platform for regional and local innovation, which will be done in a pluralistic way. But I sometimes again, this will be the last economics term I use, I promise, but we economists talk about network economies, which emerge when everybody's using a standardized approach to something. There are times when you don't want to do that. One time you do is something called Microsoft Word. I co-taught a course a couple of years in a row with a professor at Renmin University in Beijing, 8 p.m. my time, my students, teleconference, 8 a.m. his students. I could send him a document, Microsoft Word, slides, he could open it. We take that for granted, but we can't do that in healthcare. we can't even send it from one county to the next or from one person to the next sometimes. So there's a network economy that emerges when we have standardized approaches to certain things that I will mention, but that is very different from a monolithic approach to reform. And so the new regional partnerships, I believe there are 8 emerging from the latest grants, will be trying different ways of collaboration to improve health outcomes and reduce spending. Just a few numbers. I'm not going to, you have the report. I believe it's posted on the website of HSCRC. But what struck me is, let's go first to the 4th bullet. 14%, first of all, Maryland is a state, Bob just mentioned this before, that 30% of Medicare nationwide patients are in some form of Medicare Advantage plans. But here in Maryland, it's 8% or thereabouts. So this is a heavily fee-for-service state in Medicare. And 14% of those fee-for-service Medicare patients have 6 or more chronic conditions, and they account for 48% of spending. So this is kind of the Willie Sutton effect. You've got to go for the people that are the sickest and figure out how to manage their care. Half of those with 3 or more admissions in a year's time are Medicare only, but then there are another 15% who are duals. That means that 2/3 of those with 3+ admissions are Medicare enrollees. There are other populations in need. We didn't want to make the mistake of focusing only on people with multiple chronic conditions, although that's critical, but also trauma victims, people, frail elderly with cognitive impairments, other functional status limitations, and ESRD patients. There are many different special needs across the life cycle, including children with disabilities. But we focused most of our attention on the population with multiple chronic illnesses. This chart, which I think was dubbed our propeller chart, I won't go into all the, I called it a butterfly chart, but then some of the members pointed out that butterflies only have 2 wings, so I switched to propeller. But the operative point of this chart is the circle on the right that illustrates the point I was making, that state-level investments in information technology in a standard, creating standardized discharge plans, standardized health risk assessment formats, and things of that nature, standardized care profiles. What do I mean by care profiles? This would indicate what medications a patient is on, what diagnoses they have, key demographic conditions, their medical history. That's distinguished from a care plan, which would be developed for them going forward. And those you don't want to probably standardize. But you can at least standardize the kind of information, fills, refills, these things, these categories that could be filled in and shared across providers, so that providers, including not only doctors, but nurses and nurse practitioners and social workers and others, can all have access to this in real time because they're all treating the same patient. You can see the 4 components: care coordination programs, electronic medical records. I want to emphasize the one on the lower left in yellow, chronic care management. As some of you know, as of January, CMS has made available special payments to physicians for spending the extra time to coordinate care for their patients, a little over $40 a month. That's $500 a year per physician for care management. We think that is a way to bring revenue in to help support this care management and get physicians invested in spending the time. They need a little bit of money to cover their time. It's not typically billable as a CPT code, so this will help encourage and incentivize them to do it. The Medicaid dual eligible ACO, Laura can tell you more about that. I think we'll be moving ahead. Dual eligibles have been not in managed care in Maryland. That's going to change, and that's an exciting possibility because it's a population in great need. We took the view, one of the things that happened in our meetings early on, we started talking about acquiring CMS data, which I'll comment briefly on in a minute, and several of the people on the panel said, well, wait a minute, yes, we do have to acquire claims data that can be identified to the patient in order to develop the care plan. We have to know who the patient is. That requires HIPAA protections and privacy and so forth. But before you go off on that, not before, but while you're going off on that, don't forget about the data we have now. Administrative discharge and transfer data, ADT. When I first saw that, I thought it was an alarm system, but then I realized it's a very valuable source of data. OASIS for home care. PBMs have data on pharmaceuticals and minimum data sets for nursing homes. You're aware of these sources. So one activity is to synthesize and organize and interpret the data we have on high needs patients in hand already. But a second vital to-do list item that came out of our work was to go to CMS under Maryland's existing grant from CMMI. It does not require a new arrangement, get it modified, but to obtain Medicare claims data on an identifiable basis. And you can do that by showing that it's going to be used for care coordinations by providers, and that would support the goals that CMS has already agreed to foster with this grant program. So leaders in the state will be moving forward to get that data and use it to identify the highest needs patients. We view this as a three-stage process. First, risk stratification to identify those patients, particularly in Medicare. I've given you one, how many have multiple chronic illnesses. There are also inpatient admissions, how many times you hit the ED, diagnoses. There are various ways to do it. But we know that there's some 40,000 or so of those patients who would be in great need and great benefit right now. Risk stratification would be followed by health risk assessments that are done in usually a face-to-face basis and to determine what the real needs are of each patient. But you can collect standardized information. You can have a standardized patient consent form and to get that going so that these are some of the investments that could be made. CRISP is a vital player here. You have an important role to play with CRISP, so you know about that. This creates these kind of network economies that I was talking about so that these records are shareable and viewable and helpful. And then that would be followed by the preparation of the care profiles for each patient that both Carmela and I have mentioned, leading to individualized care plans. And another vital component is electronic notification system that's already underway. The minute a patient hits an ED or is admitted to a hospital, that patient's medical home and patient-centered medical home or any primary care provider they have is alerted electronically. I even discovered one community health center in Baltimore, Absolute Care, that will send a van. If somebody comes in the ED and they really didn't need to be there, but they didn't know that, instead of just saying go home, they are a community health center in downtown Baltimore. They will send a van over and pick them up almost at any hour of the day and bring them in. You know, you could have come here. Let's take a look at what drove you in there. That's sort of an immediate feedback. Okay. So I'm going to move quickly, in the interest of time, through this. I've pretty much covered this, so actually I think I'm just going to move on to the next slide and briefly mention the key elements that we believe are comprise good care coordination. And a lot of this is based in the literature, and some of you certainly know this. Smooth transitions across the spectrum of care, smooth handoff. So many patients fall over a cliff, particularly when they leave a hospital. We know that home visits work. They're better than telephonic, although telephonic is better than nothing. There's also transitions of care from people in a nursing home who keep cycling back into the hospital, even things that could be treated on site that are comparatively mild. Once they hit the ED, they're going to be admitted if you're in a nursing home. And they may be there 3 days or 4 days, which sometimes will actually make them worse if they didn't need to be there in the first place. Active medication management. I've been fortunate to go on rounds with attending physicians and part of the research where see a pharmacist goes with the attending on the round and is right there working with the attending at every doorstep in the hospital. Behavioral health integration, I just want to say a word or two. I've already commented briefly, but that this is a two-way process. We had at least 3 experts on behavioral health on our work group, including Adrian Ellis and Lori Doyle and so forth. They're really good, knowledgeable people. But first, working with primary care physicians and nurses in an advanced medical home to alert them to the symptoms of behavioral health problems and get the appropriate referrals in a timely basis. Sometimes this involves co-locating primary care physicians in a behavioral health setting and vice versa. But also something that isn't realized a lot, which is alerting behavioral health providers, psychiatrists particularly, to the impact of their treatment, particularly medications, on a patient's physical health. A number of these medications may lead to serious weight gain, which then in turn leads to diabetes and other heart disease. And titrating the medications and working with a physician who might be an internist or specialist to reduce such effects while still getting some medication with patients. So understanding it's all one body and that physical health and behavioral health are not totally separate. I've already mentioned services in the delivery model for kids, but one group that came to talk to us from San Diego, 4 hospital systems out there, Scripps, Sharp, University of San Diego, and so on, they got together and they were rivals, and they usually sat in the 4 corners of the room and never talked to each other. One of the things they discovered that they could work on together was that throughout San Diego, there was a shortage of Meals on Wheels. There wasn't enough resources, and that was driving people into all their systems. They were not getting appropriate transition. So one recommendation to come out of that is, why don't we work together to get some more, advocate for some more resources so people aren't going hungry? A lot of people now are having their electricity turned off, particularly seniors. That ain't good for your health, particularly in the winter. So that's what I mean by the social service model being coordinated into the delivery model. One of my colleagues, I spent the summer of 2013 at UCLA School of Public Health, and Jonathan Fielding, the leader there, likes to say, I don't know that he invented this term, that a person's zip code may be more important to their health than their genetic code, and that's often the case. A supportive HIT, you know this, home visits I've mentioned, embedding care managers in a primary care setting, and that works. Telehealth is very important, including telepsychiatry. And ensuring, I'm almost done here, I don't want to take up too much of your time, I'm going to skip to the end. Ensuring a workforce of adequate size and mix. We have a healthcare workforce in America that is absolutely appropriate for taking care of my parents, but it's not absolutely appropriate for the needs of an aging population where all these problems I've described spill outside the traditional model. You can't do it without doctors and hospitals, but you need a lot of other people. And we have shortages in Maryland in so many professions. I've just gone over the data on psychiatrists on the phone driving up here on Bluetooth. I've got the data that I'm using. It's pretty startling. So let me jump toward the end. I think I'm going to skip this slide, and you know about some of these things, and move on to my summary so that I don't take up too much of your agenda. Okay, let me wrap up by saying that the all-payer model creates incentives for hospitals to keep people well. And they were always trying to keep people well, but now it's in their interest to keep people well. And there's so many, not only the all-payer system, but the new penalties on readmissions have gone up from 1% to 2% and so forth if they don't meet their targets. And hospital systems now, we heard from, I think, Western Maryland, and Frederick Memorial came in and made a presentation. Hospitals and Bon Secours came in and made are working to reduce readmissions, and they're working with partners outside the hospital. And the J-CHIP program at Hopkins, there are a number of exciting examples to address these programs. Need to identify people with the most complex medical and social needs, create individualized care plans to meet those needs, build a platform to support care coordination, find the best mix of standardization and flexibility, and then finally address the underlying cost drivers, many of which fall outside the medical model. So I'm going to wrap up there, Laura. If there's anything you would like to add, please do.
Yeah, I will just say that, we know there are multiple care coordination activities happening around the state already at the payer level, at the hospital level, at public health, community-based organizations, and the work done by the work group is as Carmela already said, the how, and what's the framework with which to move forward, and what do we all have to agree is the right way to meet the needs of individuals. I've certainly heard anecdotally about individuals getting care coordination from multiple entities, and then other individuals who really need the care coordination not getting serviced by any of the entities. And so from public health perspective, it was not only how do we align those efforts, but as we move forward, as Carmela said, to the second 5 years and the total cost of care, engagement with the community and community-based organizations for long-term success of these individuals with complex health needs is really going to be important. And certainly, what is the role of public health in working with hospitals in their area and with other community-based organizations, which we have done successfully for years. So it was a pleasure to work with Carmela. I think the paper that Jack and the rest of the HMA team put together have really spelled out immediate next steps that we can take to move a comprehensive care coordination strategy forward.
Thank you very much. I think we're going to have a good conversation, and let me tee it up a little bit. I think the way I liked how you framed it, Jack, which was you're saying, hey, we're predominantly fee-for-service Medicare, and there's, the key issues are at least the core population is those with multiple chronic conditions. I guess my perspective is that there's probably less controversy about the what should be done than real open questions and practical questions about who does it and how it gets done and all of the overlaps. And I'm just trying to track on a practical basis sort of the ultimate perspectives of the group. So I hear the data infrastructure and the care profiles, but I'm trying to walk through, for example, is there a view upon what an ACO should do versus what, the broader sort of state infrastructure is. Can you kind of pull that out a little bit of the emerging perspective around that? Because when I look at all the care coordination, it makes sense, but then I want to get more clarity around your vision of who should be doing those activities.
Sure, and let me try. Public policy is often not a nice, neat, sequential, elegant package. and quite frankly, I think we have to remember that as we think about this all-payer model. That is, we have a 5-year experiment that involves hospitals only. And what we're currently doing is beginning to build the connections, the partnerships, the interactions that help us manage the total health dollar. But I think that's important because, if we just stand way back, the payers have largely been doing the care coordination activity, right? That's been bolted on to some of their efforts to coordinate care. Enter global budget. So we've now just shifted risk from payers onto hospital organizations, and the care coordination becomes critical, essential to our model as well. That's where some of the duplication comes in. And we are working collaboratively, but yet none of the other providers are yet part of, if you will, the full set of economic incentives that hospitals are a part of. So it's an excellent question in terms of the who. Maybe what I can do is just give some examples. I very much think of this as an environment in which there are 1,000 flowers blooming. The thing we know about care coordination is it's local and it's personal. And that makes this work very, very difficult and very, very challenging. We just held a summit about a week, maybe 2 weeks ago with Lifespan, with the post-acute providers in the state. And it's all about cross-training on Interact and warm handoffs and beginning to now data share around readmissions, taking a look at what some of the best practices are. And so, the WHO, we're trying to expand the net of the WHO, but quite frankly at the moment, it is hospitals who are holding the risk and looking to partner and collaborate with others. I tend to be a little, myself, model agnostic. That is, whether it's an ACO or a PHO or whatever it might be. I think there are different models being employed out there. And one of the challenges here is we've decided to start with this sector. And what we're really trying to do is coordinate care across the entire continuum. We had an opportunity, I had the chance to chair a transition steering committee that was in place for about a year and a half, pulling all of the different state organizations involved in the full care continuum spectrum together. There is a lot going on out there that we probably haven't touched on, but I think you raise an important issue. It's not clear-cut. It's not a nice sequential organized path. Laura may have other thoughts.
Sure. Thank you for this presentation, and I'm going to dive in and read every piece of that report. So I guess following up on Craig's question, getting to the who. So we've got some of the what are some elements of care coordination. And I hear you say that rather than be standardized across the state, to allow for local innovation in these partnerships and in regions to develop different models. But I guess I have to ask the elephant in the room question, which is to say, who's going to pay? The example that Jack gave about the Meals on Wheels deficit, and that was really helpful to understand that was a problem. In the environment that we're in social services, in public health, and elsewhere, the hospitals can't go to Meals on Wheels and say, ramp it up, we need more. Okay, that's just not, so there's not going to be outside revenue to come in and to bolster any of these community or social needs that are going to be identified through care coordination. I mean, there may be some, but it's wishful thinking in large part. So I guess, the hospitals now are holding the risk, but they're also holding the potential. So I guess I have to ask, in this situation, if that was in Maryland, would the hospitals then be saying, okay, we're going to buy some more Meals on Wheels? I mean, is this, so care coordination, if it happens through a health department, that's going to be through a financial arrangement between the hospital and the health department to bolster on particular protocol-driven activities that previously hadn't happened. Is that kind of, I need to ask that because otherwise we got a lot of good ideas, but we really don't have the fuel to get the vehicle underway. Use that metaphor.
I'll jump in again, and this would be an important conversation with the HSCRC as well. We're living as hospital organizations now under global budgets. So to your point, anything we can do to either lower the cost of care or prevent unnecessary care within that global budget becomes in the economic interest of the organization to make that happen. So that's very different than a fee-for-service model where you're right, it's in no one's interest. It's, well, can you please, as you said, go ahead and ramp up Meals on Wheels. Having said that, the HSCRC, as it's taking a look at setting global budgets and increasing those global budgets on an annual basis, is looking at the infrastructure investments that are needed in communities. There is a specific line item set aside for those infrastructure investments. Every hospital has been asked to submit a detailed report of the infrastructure investments they have made so we can get a good, better, solid understanding of the kind of partnership investments that are needed. And it's everything from hiring care coordinators and care managers. There's an experiment going on, University of Maryland, Upper Chesapeake, and Lorien Health, where they're using the EICU camera technology basically in the skilled nursing facility so that rather than dialing 911 at 2 o'clock in the morning when a physician is unavailable, they simply ring up the emergency department physicians who can look at the patient and potentially prevent the readmission.
Don't we pay for that? We pay for that.
Thank you.
Yeah, we know about that. So that's sort of like, that makes my point. It's like outside of the system, we pay for that.
So, and and so
Maybe
that's-
that was seed money on the
Well,
investment.
exactly,
Okay.
and that's a critically important point, which is there is seed money that's needed. One of the things that the HSCRC's advisory council said to them is we need to err on the side of making certain we're making the early investments if we want to have the long-term savings and sustainability of this system. So some of that is built into the rate-setting system. We have been working with the Rate-Setting Commission to make certain that the amounts of those investments are adequate to put in place what we need now for 3 and 5 years down the road.
And I will just add, some of the hospitals are already have these relationships. Worcester County and Atlantic General Hospital, they've partnered with Worcester County Health Department because of their experience in the community managing individuals with chronic disease. And I think the focus there is on their readmissions around diabetics. But some of the hospitals are starting to understand what the community brings to the table for success or the reduction of admissions and readmissions, and using their own resources to start it. To the point about payment, I think it's a flat fee or a PM that's aggregated, but the HSCRC is exploring additional payment models, as Carmela said, to bring in those providers that have not been on the table, and how do you include them in the incentives and quite possibly disincentives for doing this care coordination right.
Thank you, Mr. Chair. Thanks for a great report. In Howard County, we have a pilot going on where we have the health department doing a community care team. We have the hospital doing some work in that area. We have plans who are doing that. We have home health care doing this. And in meetings that we've had where we brought everyone together, there seems to me a sense of, well, this is our job. Well, this is your job, and a lot of this stuff going on. And when you point to the challenges of coordinating the coordinators, how is that ever going to be worked out? So let's assume that we have this all paid for in some sort of way. There still is that sense that the overlapping responsibility of the plan wants to reduce the cost for the employer. The hospital is trying to reduce readmissions. The health department wants to make sure that all those wraparound services are available. How does that occur in the future as we think about making this sustainable over time?
So that's when we go to the Hennepin counties of the United States to figure out. So Hennepin Health had the same exact issue and actually found, because of the number of care coordinations, that actually increased total cost of care. And then ultimately they needed a care coordinator for the care coordinators because there were that many. And I think there are certainly enough jurisdictions around the country where this is happening, and we would just reach out, or we have been reaching out to understand how they finally got everyone at the table, so that you didn't have not only these turf wars, but then areas where it was just assumed that another entity was taking over. And I think CMS has certainly been talking about it, but as we think about holding communities accountable for their care, then I think it will be easier to understand who will be doing what for whom and where.
And if I can add, just a reminder, we're only 18 months into this. It's still quite new. But Glenn, I think your point is a very good one. This is about community engagement and coordinating community-based activity. It's a very different feeling than here's my box and I'm responsible for what's in this box. I don't think that if there is confusion or overlap, I don't think that is unexpected. But we've got to figure that out over time. I think what we're now seeing is a greater focus on partnerships, and quite frankly, partnerships around issues related to the triple aim. So if hospitals are going to work together with post-acute providers, who are the right post-acute care providers to work with, and how can we both be focused, for example, on readmissions? So I think you're beginning to see greater alignment in the communication, in the efforts, and what could ultimately be more economically aligned partnerships among the various players as well. Probably less so when you get into the social service areas, but just some thoughts.
Jack, I'm going to ask you because I've known you for over 25 years as a first-class economist. And, first of all, this was an excellent presentation. But I want to ask you a very specific question about the problem. We're looking at it from a supply side. In other words, we're looking at how hospitals, for example, and other institutions can do a better job in case management or care coordination. From the standpoint of the demand side, which is kind of probably an inappropriate use of the term demand, but you know what I mean.
Yeah.
The patient side. A lot of these problems, many of them, are, especially with people with chronic diseases, a lot of these problems are people not doing what the doctor tells them to do. The doctor tells them to stay away from cigarettes, they don't do it. The doctor tells them that they've got to stop relying upon sugary drinks, as a recreational food all the time, and they don't do it. The doctor tells them to do what they can to lose weight, they refuse to do that. And then they end up, going, from time to time, they end up going to the hospital emergency room. My question is, I understand all this the importance of all this in terms of, trying to figure out how to develop a more sophisticated social services. I get it. The Meals on Wheels thing, I'm familiar with that, by the way, in San Diego. I happen to know about that. But how do you incent the patients to do what they are supposed to do? My question to you, Jack, is how do we get these people engaged to take ownership of their own health and start to make rational decision-making in accordance with what the physicians are trying to tell them? Because I know members of the medical profession that I know are concerned about this, but when it comes to things like adherence to pharmaceutical regimens or behavioral changes, they simply don't do it. My question to you is, given the fact that a lot of this is chronic illness, a lot of this readmission, is based on this sort of problem, how do we get patient incentive? What economic incentives can we build into this system?
Well, Bob, very thoughtful question as always. I've always viewed our problems with rising healthcare spending as an interaction of demand and supply. It's not either or. You can't leave the patient out. What I've found in areas ranging from diabetes and obesity, smoking, and any of these things, is the first thing you can do is have a model that features coaching and positive incentives over scolding. Scolding doesn't work. There are plans now in this state that set up a kind of debit card, I'm talking about a health plan, for a patient for wellness type activities. That debit card can buy down their deductible, can reduce their deductible a certain amount. Now there are limits on this from ADA and other legislation on what you can do. But there are incentives for people to do this thing. People seem to respond, not immediately. It's not overwhelming. Coaching helps. I smoked a pack and a half of cigarettes from age 15 to the day I graduated from college, tried about 4 times to quit. It was one of the hardest things I ever did in my life. It wasn't because I didn't know it was bad for me. I did. It's hard. It was addictive. I think that those kind of incentives can help. I also think, back to a question that both Fran and Craig raised.
Let me interrupt you just there
Okay.
for one moment. Are you suggesting that these people should get some kind of a debit card?
Yeah. Yes, I'm saying you can have a reward system.
Right.
It's not unlike an HSA. It could be built into that model, but it doesn't require an HSA.
No, right, okay.
There are limits to it because there are things beyond their control and things within their control, and there are legal constraints on it, I've found out. So you have to be careful. And I'm not saying, and I think there are limits to how much you can achieve, but I do agree with you. The patient has to be a part of it. The patient has to fill the script and refill it. It can't just be prescribed. I agree with you.
That's okay.
But I also think it relates to something that was said earlier. In addition to how we pay for these new resources, like Meals on Wheels, it's not just advocating for more spending on them. It's working with doctors and others in the medical system to learn to think about, I wonder if that patient is hungry. I wonder if that patient, what's their home life like? They don't, it's not just more resources. It's also team-based care, all of you have situations in your family and friends where somebody's seeing 5 specialists who don't interact with each other much. They're prescribing 12 medications. They're over-prescribing, they're drug-drug interactions. Okay, you don't need to spend more money there. What you need is, and I think having these kind of IT platforms where, you know, in one case in my family, somebody's seeing an orthopedic, rheumatology, dermatology, pulmonologist, they don't talk to each other. They don't communicate very well with her. And she's a very educated person. So it's not just more money. And it's learning to say, I wonder if we need a social work in here. I wonder if she's depressed. She seems depressed. That's not my field. Maybe, you know, it's that kind of different delivery model. And then we need to think, how can we facilitate that? That's what we're kind of trying to do.
Point, because there are some policy levers, probably few. Some people, I don't want to suggest in Maryland, but some have talked about, you know, tiering premiums. But it's that facilitation word, and some of the work that's going on right now is if adherence is an issue, how do we make it less of an issue? And it's, you know, whether Uber or Amazon or Target, you know, the fact that you can pick the phone and order something and it's there in a moment or there in 12 hours, I don't even know how they do that. What can we do in care delivery? So as an example, many hospitals are now moving to medications at the bedside. So instead of giving the patient the prescription, you're creating an opportunity for that prescription to not be filled. Instead, the patient goes home with the medications they need. The patient goes home with the follow-up appointment already made. So you don't create the opportunity, I'll get to that, that's what I always say, I'll get to that, and you never get the follow-up. So how do we also think about it as a facilitation role back to that coordination to get patient adherence, consumer adherence where you'd like it?
Maybe there, let me just point out one thing and then we'll get to Catherine's question, is that there's a category of recommendations that weren't in your report, which I think is around regulatory barriers, because I think this specific example that Bob brings up, I would say that in high-risk elderly, the most effective intervention you could do is actually give them a smartphone where they push the button when they need to get in contact with advanced primary care practice rather than go to the ER and urgent phone. 50% don't have phones, but you can't do that because of Medicare regs. That's inducement, at least on the MA side. I'm not sure it's allowed on the fee-for-service side. So there's some regulatory barriers that prevent us from just being very practical about substitutions. And I just think there may be an opportunity to really make it easier for the practices over time to innovate there, because there are definitely some barriers.
Including occupational licensure and scope of practice.
I applaud it. I know this is an extremely complex issue, and I think where my question is really leading off of Glenn's is that there's a lot of innovation, very disruptive. I think by basing the waiver impact on the hospital because of that risk, is following through with trying to push some of that innovation. My concern is the behavior, the culture, structures of how hospital entities, hospital systems look at healthcare tends to be very biased to the acute end of things because that's what their business is. And my concern is that in these partnerships that I've observed, that have emerged, and it's just an observation, it's not empirical, is that many of them are very focused on 30 days. We're interested in you as a client at 30 days. Now, the global budget's not going to sustain that kind of behavior, but I don't see it changing in the partnership. So I think there's a real challenge to create a balance between the driving forces that are there with the hospital community, can't do without them, integral to the part, in integrating that into the fabric of the community so that there's also as much strength. The community, whether it's an individual practice, whether it's a group of practices put together, or it is a health department or a community, don't have the same kind of clout as a hospital. So they tend to be not truly, at this point, it may shift, a true partner at the table. They tend to be told or directed what to do by the hospital community. And I'm concerned that the balance, and in order for it to really be effective, there has to be that kind of true balance at the table of the partner community. And I think it's a huge challenge because we are so hospital-centric, but the solution is not to be hospital-centric under the waiver. And so there has to be a real conscious effort to shift that. And the preventative work or the avoidance of one more comorbid condition becomes very significant to the sustainability, if it's even possible in the time frame that's been structured in 5 years, to be able to get the money out of the system, to be able to get that triple aim, to get that quality up. It's not just about the 30-day readmission or the inappropriate use of the ED, but most of the structures now, most of the frontline communication now, by my observation and experience, is very focused on a very discrete part because they don't yet either understand or have the capacity to take on Meals on Wheels. It's a great thing to do, increase Meals on Wheels. Well, how's that going to happen? And I think it kind of goes back to that as sort of a hypothetical example, but a real one in some cases. So I think that's a bigger challenge, way beyond the scope of what you all intended to do, but very significant to pay attention to as we move forward, because paying attention to and monitoring the actions in a very hospital-centric model could result in some real missed opportunities or failures.
I wonder if I could just offer one observation. It's a reminder for all of us that this is a CMS demonstration project, and part of this, we are testing something on a statewide level that hasn't been tried or tested before. I think your observations are very important, and in some communities, spot on. We talk about the H, the blue H, the sign everyone knows, that it's about that H no longer meaning hospital care, it's that H means health care. And that is a dramatic transformation, as you've just talked about it. Our CEOs, our leaders in the state talk about turning a barge 180 degrees in the mouth of a river in about 365 days' time. So, are we there yet? I'll leave you with a thought, a quote, Mickey Mantle. It's unbelievable how much you don't know about the game you've played your whole life. And that's very much, in a sense, what this is about. Many of us have been involved and engaged in healthcare for decades, but the game has changed. And so it's about learning and all of the things you've just talked about. It's not just about acute care. It's this transformation where the economic incentives that we now have because of not only CMS but the application of global budgets has actually aligned interests in new and different ways. And that's the better mousetrap that we hope comes out of it.
This is Commissioner Solomon.
Yes, Diane?
I find this discussion fascinating, and I apologize for not being there in person. I really wish I could be. The work that's being done around care coordination is vitally important, and it mirrors work that I see happening in a number of states across the country. The comment about the H as far as being hospitals, which are sort of the most extreme aspect of, if you will, sick care traditionally, and trying to then reshape that to be more about health care. There are a number of entities that have focused on health for years and really are, I think, by consumers and patients, by individuals in the community, back to the point that was being made earlier about engaging patients and taking care of themselves better. They don't tend to think of hospitals as the health promoters. The hospital is a place you go to when you get sick. So I just would encourage all of this work to really look to the institutions and the structures and the organizations, whether it is family medicine or it is the other services in our communities that really are, that do have quite a bit of experience in terms of focus on health. So it's not that this is a brand new area for those groups. It may be brand new for those who have focused on taking care of people and doing it quite well. They're taking care of people when they're sick. So there's a lot of incredible experience with community partners pulling into this work, so that it's not just about the hospital, but it's those partners and learning from partners and letting those partners actually be leaders in many of these areas, I think, is essentially important.
Thanks, Diane. Okay. Others, Ben?
So I wanted Jack to go back to his propeller diagram. I wanted to make certain that the commissioners are clear on that, and some of the concerns you have voiced and questions you've asked, demonstrate, there are going to be, the work group did not agree on a model. It focused on the infrastructure necessary to hopefully support multiple models because, frankly, the evidence is not yet there to identify a model that's going to be perfect for the state. But I think the focus of where the dollars go is really on the health IT infrastructure in the state that would need to be built to sustain the, someone used 1,000 flowers. I think that came out of that old healthcare reformer Mao Zedong, but I'm not sure. But in any case, there are going to be models that are going to have to be very much honed on what's suitable for the community. What works in Western Maryland probably is not going to work as well or without significant changes in Baltimore City. But the premise of this is that this sort of hypothesis is that we can build this healthcare IT utility that would be suitable for many models. As I understand the sort of essence of the work group, and HSCRC, as they will authorize the funding for this, are essentially the venture capitalists here. Does this make sense? MHCC as commissioners, as potentially partners in that, would also be weighing in at appropriate times on does this make sense as these plans come down the road. The question in this soliloquy is to Jack probably is that venture capitalists like to supply gasoline. They don't like to build cars, and so tell the commissioners how much of the car you think is there that still needs to be built in the development phase before we can, the big investment, the gasoline, is plugged in that's going to support all these different models going forward.
Well, that's a good question, Ben. What I found, one of the papers and all the studies I reviewed and getting ready to draft this report and redraft it with my colleagues was a good paper by a guy named Lyle Nelson, I think at CBO. And oh, he was, okay, consultant to MHCC. That's why he's so good, no doubt. But what he did was so helpful. So there are 34 demonstrations run by CMS on care coordination, okay? And if you average them all up, which is what some people do, and say, what's the average effect? It's 0. Okay, so I've had many people say, so that didn't work, so nothing works, so why are we even doing this? But what was interesting about his paper, he said, well, actually there were 6 or 7 of the 34, one of which was HQP, which you put me onto, Laura, in Bucks County, Pennsylvania, Health Quality Partners, and Massachusetts General had a success. There were a few, well, what are they doing that the other 27 weren't doing? And it turns out it was things like embedding care managers in a primary care physician practice. It was things like strong medication management. And many of the elements that co-location of services between behavioral health providers and physical health providers. Those things emerged as, well, they're in the ones that got a good ROI. That may be spurious, but it sure would want you to. So, some things we know that home visits work better than telephonic from the literature. We know that you can't make the cost of care management too high because then you won't get a positive ROI. That means you can't always use the nurse. I mean, there are some things that don't have to be done by. So studies like that can be helpful. We can go to school and begin to learn what works, and I agree there's no magic bullet, but I do think that having this platform of shareable profiles and getting the providers to share information, compare notes electronically, huddle in teams virtually or literally does make a difference. And so, I think that's how I would answer that.
So maybe I'll answer it the way I was thinking that we can say, I mean, it's the infrastructure that we need is the hospitals are all connected. The information flows bidirectionally. They publish information to our Health Information Exchange in the state. They receive information from the Health Information Exchange in the state. Critical to this actually working is much more broad information exchange here in Maryland, particularly the bidirectional exchange of information from community-based providers, not only physician practices, but ultimately community health workers, whoever they tend to be, which are not really even fully conceptualized yet. So the information framework that's key to this is built out for hospitals, but yet to be built for mostly for ambulatory providers, changing day by day. But it strikes me as when we talk about what we're asking the state to invest here is large. It's a largely IT project at this point, done not in a big build, but incrementally that we'll have to undertake. And wave version 1 of this information platform is probably not going to be the perfect one, but it's going to be good enough to support these care coordination models that are going to develop and will vary quite a bit across the state as they take root in communities. So I think it's my recollection that in terms of your dollar estimates for that initial activity, most of it was for further enhancing the data infrastructure, and then on an ongoing basis, maintaining that would be the bulk of the cost of this initiative. I think that's really important, to keep in mind. The care coordination activities and how those would be funded, I think, are still left to individual systems, individual communities to figure that out. There's no fee that we put into the recommendations that said, well, care coordinators should be paid X or Y, but you did have estimates about what you thought this component of the software development or the hardware would cost. And I think that's something that commissioners need to keep in mind, that and MHCC will be, as we oversee CRISP, we're going to have some responsibility for that. The funding will come through approvals for rate increases that HSCRC will have to make, but we're going to have to make ongoing judgments along with our partners. And I think that's something that I want the commissioners to be very aware of, that staff will be monitoring, and we'll be coming back to you asking the CRISP partners and others to report on progress that's going to be made through this. Naturally, trepidation with IT is not something that we should take lightly. It's a completely different system, not nearly as, in some ways, integrated, dealing with a federal data hub, for example, but yet, in some ways, not specified, not nearly as specified. There's, 2 catalogs of data specifications for communicating with the federal data hub under the Health Information Exchange. Here, it's going to be much more, the design work is going to be very, very important, I think, going forward, so we can make this infrastructure acceptable and usable to a variety of providers across the entire continuum of care. And those are going to be design challenges that we will be counting on CRISP and its partners to really wrestle to the ground in a fairly rapid process. Certainly, there's going to be others, and I think the hospitals and organized health systems are going to have to be very, very attentive to how those dollars are going to be spent and is it going to be usable, as well as the amorphous community providers, which are going to have, it's going to be hard to nail down what's going to be useful for them. So this is a very challenging, important initiative, but as I see it, more important from the standpoint of the information infrastructure than necessarily we're all agreeing on the care coordination model that's going to evolve here.
And could I just add 2 thoughts to that? Then I think you've articulated that nicely. I know Chris is working on creating a steering group, a work group to manage this. But there are also important policy issues underneath this IT infrastructure. The first one we have to wrestle with is patient consent. And this goes to the issue, this is only successful if it is bidirectional, but that's only successful if we're sharing all of that information. That will be a challenging issue, and we had a lot of conversation within the work group around that. The second is, of course, this lack of longitudinal data, the lack of the kind of data that payers have from a claims perspective. If you want it to be bidirectional, you've got to have much more to share than just what's going on hospital, and we've got to connect that as well. So we've got a number of policy issues in addition to the data infrastructure build for us.
I might just make 2 simple suggestions, and since Ben used the car analogy, I'll run with it. I guess if I was saying that the state level IT could help the primary care physician who's taking care of these patients with multiple chronic conditions, I'd have 2 asks. One is, can over time Medicare fee-for-service data be up to the same level as the private sector through Medicare Advantage in terms of speed, accuracy, all of that, because there's a huge gap today. And then that's sort of the rear view mirror, because at best it's a couple months. And then from, if you're driving the car, you want to look at the front windshield. So you just, on a very practical basis, what happened last week? How do we get that data? And, so the ADT is part of it, but there could be other things. I think until we sort of get that kind of level of, feeling like you can really drive the car practically, it's often very unhelpful from the doctor's perspective to be told, well, hey, look what happened 9 months ago. It's not as actionable. Any other comments? Otherwise, I thought this was a great discussion and appreciate you guys coming.
Thank you for the opportunity.
Okay, we are on agenda item number 4, which is the Institutional Review Board. Srinivas Radar will present a request for approval for recognition of the Johns Hopkins Bloomberg School of Public Health IRB to review the release of the data to the School of Public Health instead of the Chesapeake IRB, as was done for the DHMH IRB release of the data to Hilltop last meeting. Srinivas?
Thank you, Mr. Chairman, Commissioners. This is going to sound very familiar from the last meeting that you heard. And in essence, as we've talked to you before, one of our planned strategies is to establish centers that do research with APCD data, Maryland APCD data in academic centers. And I think one of the places where that could go well and has specific interest and expertise is at the Johns Hopkins Bloomberg School of Public Health. So what we have tried to engage them to do is to use this data for a pilot period. We plan to give it to them without a cost for for a 2-year period so they can develop their R01s and other grants and so forth. And then as they get grants, the idea would be for them to pay for the data. And so that's the sort of quick tour background of what it is. We're also engaging University of Maryland in the same effort. And so with this, of course, as part of making it as easy for them to begin using the data and show and create value with the data, we want to make it an easy process for them. Chesapeake IRB today does not truly serve as a privacy board, which is probably better for some of the this type of data and research, whereas the School of Public Health does. And so we'd like to designate them, recognize them rather, as a IRB that is recognized by the Commission. So this is the same sort of process. If you approve it, it would be for this project. It would not be for any other Commission release of data for the MCDB or any other data. It would be just for this project. And so you have in the slide just some information on their sort of current approvals and length of approvals and all that. As you might expect, they're well certified to do this. So if you have any questions, I'm happy to answer them.
Okay. First, get a motion to approve the use.
So moved.
second. Okay, terrific. Any questions for Srinivas? Comments? Okay, all in favor? Aye.
Aye.
Opposed?
Aye.
Thank you.
Okay. Motion carries. Moving on to the next agenda item, which is proposed amendments to COMAR 1025-17, benchmarks for pre-authorization of healthcare services. As you recall, these proposed regulations were developed this spring and have been informally floated to consumers, providers, and payers. And Nikki Majewski is going to present the proposed amendments to the benchmarks. If the Commission votes to adopt these permanent regulations, they will be published in the Maryland Register, and a 30-day comment period will follow. Staff will review any comments with the Commission at the July meeting before final action is requested. Nikki.
Good afternoon, Commissioners. My presentation today will be brief as we presented the information that was included in your packets back in March when we introduced the informal draft of the amendments to COMAR 1025-17, benchmarks for pre-authorization of healthcare services. The notice of proposed action and the memo detail the proposed amendments, the main one being the inclusion of the fourth benchmark relating to the requirement for payers and PBMs to implement an electronic process to override a step therapy or fail first protocol. And that's also accompanied by a reporting requirement on their attainment of that benchmark. The amendments also remove some of the expired reporting requirements from the first three benchmarks, but add language that they must maintain their online processes and demonstrate continued compliance upon request to the Commission. If the Commission adopts these amendments as proposed permanent regulations, the timeline, which was included in the slide deck before you on the next step slide, would allow the amendments to be published by the end of June for a 30-day comment period that would conclude at the end of July. And in September, staff would present the amendments to the Commission for final action, and if approved, October 12th, 2015 would be the final effective date for the amendments. Be happy to answer any questions.
First, get a motion to approve COMAR 1025-17 as the proposed permanent regulation. Okay, second. All right, any questions for Nikki? Okay.
As I understand it, your amendment, the amendment basically expands the physician's professional independence. Do I read that right?
I'm sorry?
Excuse me. That the effect of the regulatory amendment is that it would expand the physician's professional independence. Do I read that right?
So the question is, would the effect of the regulations expand physicians' flexibility in using prior authorization? Do they have more flexibility than they do today? And I think the answer to that is yes, they do.
Yeah, that's all I want to clarify.
Yeah, so
Sorry.
I apologize. So yeah, so it would be enabling them to electronically override that. It's embedding that process into that electronic workflow.
I just wanted a clarification.
Oh yeah, sorry. My apologies.
You have a percentage use of physicians? So do you want to talk about that, or you want me to?
Well, we're in the process of working on the legislative report for this year, and we're collecting that data, so we don't have an updated percentage that was presented last year. But the pharmaceutical side is still kind of below 1%, and the medical side has been trending positively, but it's still below 50%.
And whereas last year, the medical side was reported at about 36%, but we are seeing that beginning to rise. And the challenge is really building it into the workflow process, and that's been a lot of what we've been focusing on, is getting that into the workflow process. As standards are developed, particularly as Nikki mentioned, on the pharmaceutical side, they will be adopted into the applications for e-prescribing, for applications that are used to check on a coverage type. So these are transactions that are being established at the national level that will roll into the devices that are already in the marketplace. So we'll see that in some ways begin to solve itself once that comes into play at the end of the year. But it is a long change. It's a fairly significant change to create a process change like this.
Any other questions? All right, there's a motion on the table. All in favor? Aye. Any opposed or abstentions? One abstention. All right, motion carries. We are now on agenda item number 6, Telehealth Grant Award. In 2014, MHCC awarded 3 such grants. All 3 projects are now underway, and many providers have expressed an interest in participating in another grant cycle. So in April, we released a solicitation to award 3 more grants, and Angela Eva and Maria Khan are going to present an update on the grant award.
Thank you, Chairman Tanio. We're excited to present to you today on recent telehealth awards made to 3 innovative organizations. In October 2014, the Telemedicine Task Force, convened by this commission and the Maryland Health Quality and Cost Council, submitted a report to the General Assembly and the Governor with recommendations to expand the use of telehealth to improve health status and care delivery throughout the state. The report identified 10 use cases as potential pilot projects that could be implemented in Maryland. Staff used the use cases to guide the development of the funding announcement that was released in April. Staff believes that the experiences gained from these and other pilot projects will inform the design of new programs and larger telehealth programs throughout the state, particularly as it relates to the facilitation of care management and care coordination. I'll turn it over to my colleague, Myra, to present the telehealth grant.
Thank you. Good afternoon, Commissioners. So the MHCC is awarding a second round of telehealth grants. The first round was awarded last fall to hospitals and nursing homes to assess the impact of using telehealth to improve care coordination and to reduce hospital encounters, which you all heard about in the care coordination presentation earlier. Now we are awarding 3 more grants in the second round with about $30,000 available per grantee. We received a total of 8 grant applications, and the 3 strongest applications were selected by a review panel that evaluated the applications. The overall goal of the telehealth project is to improve the health of the populations being served, to enhance the patient experience, and to address healthcare costs. In terms of the grant requirements, the projects are required to use telehealth technology as a way to improve access to care, enable early treatment, and reduce hospital encounters. And then in order to optimize the use of health IT and facilitate care delivery, grantees are also required to use an electronic health record as well as services of the state-designated HIE CRIS. In terms of the grant funds, a 2-to-1 financial match contribution is required from each grantee. Additionally, the grantees are expected to go live within 30 days of the award date, and that is to ensure that there is enough time for the projects to use the technology and to be able to assess its impact. So the technology implementation and care delivery processes, such as developing the clinical protocols, should be completed within that first month of the project. The proposed telehealth projects were also required to align with one of the following use cases below: use of telehealth to manage hospital prevention quality indicators, or PQIs, use of telehealth in hospital innovative care delivery models through ambulatory practice shared savings programs, use of telehealth in hospital emergency departments and during transport of critically ill patients, use of telehealth in schools to manage conditions such as diabetes, childhood obesity, and behavioral health issues, and use of telehealth for routine and high-risk pregnancy. So now I'll just give a brief overview of each of the 3 awardees and the specific use cases that they had proposed and were awarded for. The first awardee is Chrisfield Clinic, which is a family practice clinic in rural Somerset County, and it's led by a family nurse practitioner.
The clinic plans to implement telehealth technology to 2 schools to help students manage asthma, childhood obesity, and behavioral health issues. The grant will provide remote monitoring, which will be used in conjunction with virtual consultations that are being delivered under another grant by the USDA. The project includes a care plan manager system that provides a notification alert to a care team from Chris Field. For example, if a student's blood glucose levels were to deviate from the normal range, an alert would be provided, enabling early intervention. The overall project goals include improving the clinical data indicators that they'll be measuring, reducing lost school days and visits to the emergency room, and enhancing students' perception of their health. And this project is providing well over the 2-to-1 financial match. It's over a 3-to-1 financial match. The second awardee is Lorien Health Systems. We're a skilled nursing facility and a residential service agency in Howard County. Will use telehealth to address hospital PQI conditions, including uncontrolled diabetes, congestive heart failure, and hypertension. The project will use both remote patient monitoring and video conferencing to provide care to patients who are discharged from the skilled nursing facility to home. And there will be a nurse care coach who will establish the discharge plan to avoid rehospitalization, and they'll conduct a medical and home safety assessment, as well as coordinate with the patient's primary care provider. The project aims to improve clinical data indicators for the PQI conditions that are being assessed, as well as to reduce hospital encounters. And their match is just over the 2-to-1. Third awardee is an acute care hospital in Cecil County that will also use telehealth to address hospital PQI conditions. And the specific conditions that they are looking at are diabetes, COPD, hypertension, heart failure, angina, and asthma. Patients that are discharged from the hospital to home will receive remote patient monitoring and health education as a way to improve community and population health. Union Hospital Care Management Team will monitor the PQI conditions and communicate with the patient's primary care provider if symptoms worsen, again, enabling early treatment. And this project also aims to improve the overall clinical quality indicators for the PQI conditions that they're looking at, as well as reduce readmission rates. And they are providing a 2-to-1 financial match. So in terms of next steps, the projects are going to be launching in June, and they will continue through June of next year. And then next summer, MHCC will compile the results and assess the impact of the projects between July and September of 2016. And the assessment findings are expected for October 2016. So we're looking forward to getting started with the grantees and are excited about working with them over the next year. We're happy to take any questions.
Thank you. Any questions or comments? Fran?
Thank you. Thank you for this work. I have a question specifically about the Union Hospital Award, but it's more of a generic question as well. And it goes to what the presentation we just heard about the changing in the hospital financing arrangement. Is it the Commission's role to contribute to a hospital's investment in care coordination? Well, if we do that, are we able to share in the benefits that will presumably accrue in terms of reduced utilization to that hospital? So we're venture capitalists. I get that. We're trying to promote the uptake of telehealth in new models. But in this circumstance with the hospital, we're helping them advance the steps to save their money. So do we have an arrangement where we would share, it would be gain sharing? You see what I'm saying? It's a little bit odd. I get it for the nursing home and for the ambulatory practice, but in this hospital financing world, I don't get why we're making investments to hospitals. And maybe that's not, I don't know if you had that discussion with regard to hospital applications for this round of.
Well, I think we weren't limiting the types of entities that would come forward, but we did want to ensure the sustainability of their projects. As you said previously, in our other pilot projects are seed money for continuing to implement the technology, as in Upper Chesapeake and Lorien Health are doing really well with continuing to utilize that. David, do you have any more?
So I might add a different dimension to that and think of this effort as somewhat needing a set of pioneers. And what we were looking for in these use cases that came to light out of the task force work from 2014 was to say, how do we launch forward, evaluate how well they were doing, and then replicate it? And it's hard to find pioneers outside of the hospital world, if you will, that can take this on. So last time around, we had Upper Chesapeake, who took on a particular use case. This time we have Union Hospital. It is interesting because what we'll find is those results should be scalable to other hospitals as we go forward. So I'm not sure whether I think of this so much as being a venture capitalist to hospitals, but really being more as helping a pioneer create the path forward. And that's probably one way to look at this.
So it's a kind of a time-limited endeavor by the commission, right?
Yeah, yes, it's only, the project is 1 year.
But I mean, in general,
Funding pilots.
Funding hospitals or supporting hospitals to develop telehealth for discharged patients so they can monitor the health status and avert unnecessary readmission. So we're not going to do this with every hospital that comes forward and says that they...
This goes back to the 2014 task force report where we identified roughly 12 recommendations. And originally in that report, the recommendations asked the legislature for funding to develop pilots to start this forward. And when it didn't appear that we would be able to get funding this session, through the work of Ben and our finance administrator, Bridget Zombro, she was able to sort of carve out some money that we could get the industry jump-started. And where we've gotten it jump-started, it's actually working well. And interesting to note, the last match was a 1-to-1 match on the contribution side. This time it's 2-to-1, and we see there's already one group that's tripling that.
Okay, not to belabor this, but I think that the commission now has a very limited amount of venture capital to invest as angel investors in projects we want to promote. And we need to think about strategically if we partner with a hospital, and there's not necessarily anything wrong with that, but downstream of that, if there are dividends paid as a result of that investment, how can the commission participate in those dividends?
Yeah, that's a very good question. It's a very good point.
I think that I want to strike from the record my term venture capitalist. So that I actually think probably we want to be careful about that. But I think the point that you're raising in terms of the use cases we consider for the future might be something the staff bears in mind. Theoretically, you could really tangle yourself in knots here because we've given this hospital $30,000. Does that mean they broke their global budget? Or let's not go there. I think that use cases, feedback for the future might be useful to know in terms of directions we want to fund these initiatives.
That's super. Jeff and Andy?
Yeah, fantastic presentation. And what the question that kept coming to my mind is, we talked about the granting process and the matching process and what it's designed to do. What is the mechanism to gather data so that the MHCC then can see if this was effective in doing the things you want it to do? You didn't really speak to that.
So for each of our current grants and the ones that are soon to start, we require them to identify 3 specific measures or more, if they so choose, aimed at their specific goals in terms of reducing readmissions and monitoring the quality indicators based off of their goals of their project. We require them to report to us monthly on those as it relates to their baseline in addition to what they set as a goal. Part of that, the final evaluation that will be the outcome of these pilot projects is to report on this.
And there are frequent talk about the meetings.
So, and part of oversight, staff works bi-weekly calls with all of our pilot participants to engage them in a conversation about the progress they're making on their pilots. We also work with pilots together in a collaborative format to so they can learn from each other in terms of the some of the challenges they might be experiencing through the implementation. expect to do the same through the second round.
Andy?
I just want to address Commissioner Phillips' question. The state has a strong financial interest in the health of the population already, the Medicaid population in particular in that area. And if there are things that we can do to help hospitals invest in technology that will decrease the utilization of services, some of it's the 30-day readmission stuff for which the hospital's at absolute risk, some of it's the preventable conditions, and some of it is just admissions for conditions that otherwise they'd be admitted for, then the state will see dividends in terms of decreased costs to the Medicaid program. So I think the state has an obligation to help invest in these things, particularly in the context of a GBR system that provides no capital resources for investment in these things at the base of its rate structure.
But on that point, I thought I heard Carmela Coyle say that HSCRC allows a 15% infrastructure line item, or
it's a very small
in the rate.
Yes, I'll get you. I'll
Okay.
circulate that to the commissioners.
Exceedingly small.
Thanks, Mr. Chairman. Could you tell us a little bit more about how complete these use cases are with, in terms of financial sustainability? So if I think about this, there is a cost to have Lorian call the emergency doc at the hospital. Are they tracking the financial side of this to be able to go back to, Andy's point of view of saving the system money? Are we actually going to be able to track how much money is saved, or that we reduce, 4 admissions, something like that?
It's a great question. At the end of these projects, we hope the answer is yes to all of the above. What we did require is that the applicants design a sustainable model. Now, we can't know with certainty, but part of the work that we're doing is really asking the challenging questions and offering insight to where we would see about these models being sustainable. We sense that those that launch these pilots are not going to shut them down at the end of 1 year. They have already well thought out plans to be able to show the value through the numbers, because it does come to, for the economists, it comes to a lot of is there a return on this investment? And then we want to be able to take those lessons learned and expand them to other use cases and help people, even beyond our ability to fund, to launch these forward by diffusing the technology through demonstrations. And this has largely been how this has been working.
And are we also tracking how that looks from the patient point of view? In some cases, if I just think of, some situations we've had in our county where if you have a person who is in a particular network and the telehealth uses another network that might not be in network for them, all of a sudden they have an extra cost associated, with that visit. So is that going to be a part of this process as well, to understand what that looks like for an individual patient?
Indirectly, but not directly. Patients have to opt into this program. And there's a fair amount of education that's going on to help them understand the value of it. But at the end, if there's more money, probably would make sense to do a larger or more structured consumer survey side of assessing. But I think it will be more inferential on the experience of consumers. I'm hoping it will be positive, however.
And our current projects are evaluating the satisfaction, both on the provider side and the patient side, of those telehealth interventions.
Yeah, a couple of comments, and then I guess a question as to how you deal with them. So the challenges that I've seen with these telehealth models starts around with the provider's degree of comfort with the quality of the information that you get through the telehealth interaction. So the best way to have a conversation with somebody is face-to-face. Second best, I guess the last best, is to tweet the information back and forth. And somewhere in between, these things improve. And the telehealth is good, but not great, because you still don't get the same interaction that you do from face-to-face. One of the things that's really missing is the physical exam. So if you're trying to make a decision about whether or not you need to admit somebody, you can't do a physical exam through telehealth. You can have somebody there doing it for you and telling you what it is, and you can watch it, but it's not nearly as good as having your own hands on the patient. So that's a level of discomfort that the providers have in making decisions on what. And you think with time they get better at understanding that information and engaging those interactions. You don't get a whole lot of, no single provider gets a whole lot of experience with this. And the second thing that really drives the decisions on the part of the providers, do they need to come into the emergency department or not, is the liability of saying no, they don't need to come in. What happens what protections do we have from liability in that when you're in good faith trying to decrease cost of care. I mean, that's exactly what the plaintiff's bar is going to argue. You were there trying to decrease cost of care. That's why you were negligent in not bringing this patient in. And finally, from a healthcare system's perspective, you can potentially save money by not having this patient admitted, but the healthcare system isn't the one making the decision on the other end of the telehealth. It's the physician who is billing under Part B and is effectively not able to bill through that telehealth interaction in most interactions. So it's a free interaction with high liability and poor quality of information, and that's what's really limited these things from becoming effective and becoming more commonly in use nationally. So what have they thought about those things in terms of addressing those which have been the challenges to telehealth across the country?
So Dr. Pollack brings to light a couple of good points, interesting points. There's growing reimbursement for telehealth. The commercial care is required now to reimburse for telehealth services. It's the same they would for in-person services. Medicare has, I think it's 9,900. Do you remember, Maria, how many codes there is? It seems like there's more than 100 CPT codes. I think when last we saw the list that they would reimburse for. I'm not sure exactly. We can always find that, get you that number. But what we're seeing around comfort is it's really a change in process. And I think what we're seeing from these early pioneer projects is the hardest thing is to do some of what you just mentioned, is to build physician comfort around using the technology. But what's interesting to note is that we see it growing. And once it begins, it seems to work well. But it does take a while before physicians are feeling more comfortable with engaging in technology like this. And it won't work in all situations. And that's why the physicians on the telemedicine side go, wait a second, that patient needs to come to the emergency department. We're not going to be able to do this through telehealth.
Just to follow up on that, the professional billing thing only works if it's an existing patient who's already in your billing system. So if you happen to be an emergency department provider who's on the other end of telehealth and you've never seen that patient before,
that is true,
and your practice hasn't, you have no way of getting that into your system. You've got to sort of do the interaction gratis. And that, unfortunately, is a big percentage of the time, because during the day, the primary care physician who is taking care of that patient, who's available from 9 to 5,
that is true,
9 to 4, maybe 9 to 3, is can go over and actually see the patient live.
Yeah. Still more bumps to iron out along the way, but hopefully that becomes something that can be solved as well.
Very good. Great discussion. Thank you.
Mr. Chairman. Thank you.
Moving on to agenda item number 7, the legislative wrap-up and budget overview. And Bridget Zombro and Aaron Dorian are going to present a wrap-up of the Commission's activities during the 2015 session of the Maryland General Assembly and an overview of the Commission's budget.
Thank you, Mr. Chairman and members of the Commission. I'm Erin Dorian, and I will start us off with the legislative wrap-up, and then I'll hand it over to Bridget to do the budget overview. You have 2 documents in front of you. You have the presentation that's up on the screens, and you also have a summary of all the legislation we've been following this session, updated this morning. Anything that has a chapter number on it means that it was signed by the governor and is now state law. Anything that has failed, fails. And if it doesn't have a chapter number on it, it means it was not yet signed by the governor, and bills not signed by the governor are essentially dead. While they're not technically vetoed, they don't become law except for the budget. The budget does not need to be signed by the governor. So I will go over 3 pieces of legislation, really, that we spent a significant amount of time talking about this session. The first is Senate Bill 320, House Bill 602, University of Maryland School of Medicine uterine fibroid study. We talked about this at length a couple of meetings ago, and we had said at the last time I presented that the sponsors of this bill were going out to get another entity to do the study, not MHCC, and they were able to get the University of Maryland School of Medicine to take on this study. So that is going to go forward. The second set of legislation I'm talking about is the self-referral bills. I won't go into too much details about what they did, but both of them changed the current Maryland self-referral law in a number of different ways. Neither of these bills were passed out of committee in either the Senate or the House, but Chairman Hammond asked MHCC to convene a work group through the Provider Carrier Work Group, which was established during the 2014 legislative session, to bring together the stakeholders and talk about ways to either operationalize the recommendations that this commission made last winter regarding self-referral, or discuss other changes that may be permissible to the self-referral statute. So we are starting to convene that group, and we hope to have the first meeting at the end of June. That's all I have, so I'm going to hand it over to Bridget now for a budget overview.
As well as legislation, the legislature also approves the governor's budget request. So I wanted to give you just a quick, brief overview on how we assess our budget and how our fiscal year 2016 allowance is appropriated. In June, I'll provide an in-depth outline of what our actual expenditures have been for the past 3 fiscal years, including this one, a projection for the next 2, and what our current estimates are for available funding. So briefly, the Commission operates under a $12 million assessment cap that was established in 2007. So what happens is, if we're appropriated $14 million to do our work, I can only assess 12. Assessment on the 4 sectors that MHCC serves are hospitals, insurance companies, nursing homes, and healthcare practitioners. The assessment is apportioned among those groups based on a workload assessment study that is completed every 4 years. Just briefly, this kind of shows where the Commission's expenditures and where our reserves are. So I'll just concentrate on fiscal year 14. Which was last year. You can see that the Commission spent $12.4 million. Last year we had and closed the fiscal year with a $1.8 million surplus. Fiscal year 15, my projection is that we will expend about $11.9, and we will have $3 million in reserve. Keep in mind that reserve is used to add to what I'm not allowed to assess, probably during fiscal year 2016 and 2017. Quickly, here's a distribution of how our budgets are appropriated. I split them up between this year and next, so you can see the differences. Salaries, FICA fringe in fiscal year 2016 is about $7.6 million. Communications, which includes all operations, phones, is about $47,000 in fiscal year 2016. Travel is at $44,000. General operating expenditures are about $471,000. That includes printing, any fees that I pay that aren't indirect costs. The next line, you can see that the Commission pays fees to other state agencies. So in fiscal year 16, we're appropriated about $1 million. Most of that goes to the Department of Health and Mental Hygiene. Information technology is budgeted at $118,000, and contractual services are about $5.3 million. The difference in the budget's 14.2 and 14.6. This concludes our presentation. I'll be happy to answer any questions.
Any questions? And also know we'll be going into it in depth in June. Andy?
Question regarding the self-referral statute and our participation in that panel. Who's representing us on that panel?
So it's not a. Go ahead, Erin.
So during the last legislative session, the 2014 legislative session, so last year, Delegate Hammond introduced a bill that he created a standing work group housed in the Maryland Healthcare Commission called the Provider Carrier Work Group. It's a group that we are charged with staffing, and we have to convene the group based on issues that come out of the legislature or issues that we deem would be appropriate for this group, looking at issues between providers and carriers that don't have, where another state agency doesn't have any jurisdiction. After this session, the biggest issue that came up was the self-referral law, looking into the self-referral law. So he asked that we just use that group. We are actually staffing the group. So I guess we do have some pretty big representation since we're sort of the convener
So
of the
I think,
group.
yeah, just to interrupt Aaron briefly, we are the conveners, so we would be not taking a position. We're bringing hospitals together, which have a position of changing the self-referral law is not desirable. We will be bringing the affected specialty groups that have taken positions in favor of it, and we've sought nominations from the oncologists who were sponsored one of the pieces of legislation. We will be adding representatives from orthopedics, urology, and what's the other one? Gastroenterology. The three specialties that all were behind the effort to change self-referral. We'll also be we'll have one representative from the radiology from the American College of Radiology, of course, who also took a position in opposition to the legislation. In addition to that group, as Aaron mentioned, there will be several consumers, and we will have one payers, including the United, Care First, and Cigna and Aetna. So I think it'll be a gay old time. There'll be plenty of positions that will be voiced. One of the things that we want to try to do is make certain that everyone has an opportunity to share their perspective, but we also want to give some consumer input on this. Certainly, there are more people that want to be on this group than there are seats at this table here, and that's a consideration. I think we want perspectives to be representative, but we can't include everyone. We've told the various interests that we want to be representative, but we can't put as many. All the hospitals want to be on it, as do many 2 and 3 representatives from some of the specialty societies. I think it's sort of send your best player forward is where we are.
Other questions? Yes, John.
We pay fees to the commission collect fees from any other state?
Yeah, we have in the past, and some special projects for another state agency. We have actually worked with them.
So there's nothing set up in the budget that's just an automatic fee.
All right, thank you very much. Last agenda item, Ben, you're going to provide an overview of upcoming initiatives.
What I'll do is I'm going to cover one thing that is an outgrowth of the meeting today. That relates to the care coordination presentation that you heard. In parallel to that, there's been enormous pressure to get the CRISP, the state-designated HIE, whom MHCC oversees, on board and beginning to work. We have been engaged with HSCRC and CRISP in drafting a MOU that will define how that work would be, the development work would go forward. It's my intention to sign that MOU today. What it will do is give us some authority to oversee some of the planning, to be kept abreast of progress CRISP is making, to have input in how some of these projects go forward, and importantly, have authority over the audit processes that will be needed as CRISP is playing this very, very key role. So they are anxious to get that rolling. I think that you heard the presentation today. It's extremely ambitious, and but I think key to this model working is to engage community providers in care coordination. We're not establishing a model, but we are have a very significant challenge in defining some of the infrastructure through a private organization. In the June meeting, we will bring in our partners at the Maryland Patient Safety Center. They are required to provide us with a semi-annual overview of efforts. I have spoken with Commissioner Stollenwerk about approaches that we could use to make certain that other suggestions from the quality sector are also heard when Maryland Patient Safety presents, and I'll keep you informed on what else we plan to do. We have some routine work that you typically see but didn't today on certificate of need. We'll have several of those to review. None of our major projects are yet ripe for review, but these are nonetheless significant projects. We'll also hear from the Health Information Technology Group on our state payer incentive program. The Maryland Healthcare Commission is responsible for administering a program in which private carriers in the state pay incentives for establishing health EHR systems to primary care providers. You'll get the results of that. And then we'll have some information on our from our all-payer claims database, the medical care database, on cost results for 2013 that we will present in June. So it'll be in conjunction with our other activities that day. I think we'll have enough to have a pretty good meeting, but I hope to get you out of here by 3 or 3:30. So that concludes my presentation.
Thanks, Ben. If there's no other business, I'll entertain a motion to adjourn. Second. All in favor? Aye. Meeting adjourned.